Hi, I'm Shashank Bhargav, and you're listening to Three Things, the Indian Express news show. It was the 30th of January that India detected its first case of the coronavirus. It had been a student from Kerala that had just returned from Wuhan. At the time, the government was planning to evacuate Indians stuck in the Hubei province of China, which then had been the epicenter of the virus and was under a lockdown. Back then, the number of coronavirus cases in the world had been under 8,000, and the number of deaths due to it had been just over 170, all in China. It has now been more than 100 days since that first case in India was detected. And since then, of course, the numbers have drastically increased. Globally, they have now reached over 40 lakhs, and the death toll is now reaching 2,83,000. Over this period, India has seen three phases of lockdowns, including the one we are in right now. Over this period, we have also learned more about the virus and changed our strategy against it. In this episode, we talk about how India has handled the COVID-19 outbreak so far, in what ways our fight against the virus has changed, and the challenges that now lie ahead for us. For this, we speak to Abantika Ghosh, who reports on health for the Indian Express and who has been extensively covering the coronavirus outbreak in the country. The conversation took place yesterday afternoon. Abantika, it's been more than 100 days since India's first case of the coronavirus was detected. We are now more than a week into the third phase of the lockdown. How is India doing in terms of managing the outbreak?
So the short answer is we don't know how we are doing. I mean, I can give you figures, but if you want a report card in terms of performance, good, bad, ugly, to my mind, that's too early. This morning's update is that we have 67,152 cases. The total number of deaths is 2206, which means in the last 24 hours, there have been 97 more deaths. And 20,916 people have recovered so far. That's how it is. And in terms of report card, all I can say is that a couple of weeks back, the cabinet secretary had a meeting with state chief secretaries and health secretaries, and the government of India had shared some projections in terms of the way they see the COVID trajectory going. Those projections had actually shown that by May 15th, we'd be reaching 65,000 cases. Today is May 11th. And we are already at 67,152, which means we are past the May 15 projection already. The doubling time right now is about 12.74, I think, so close to 13 days. That's where we stand right now. We really don't know how we have fared because it's too early to call it.
So let's then talk about testing. One of the things that most experts around the world say must remain priority is testing. What is India's testing strategy right now, and in what way has it changed?
So if we talk about from the very beginning, our testing strategy in the initial days was very heavily dependent on whether you had a history of contact or travel contact with a person who has tested positive, or of a history of travel to a country where the cases have been detected. But since then, we have had multiple revisions. So we have a different testing strategy for containment zones and hotspots. We have a different testing strategy for other places. We're still looking at contact. And on paper, the strategy still has foreign travel as one of the criteria, because as health officials tell us that we are in this for the long term. So as and when flights do open up, that's something that will have to continue. So that's why we haven't removed it. And then also initially we were not testing asymptomatic people at all, but now we are testing asymptomatic people if they have come in contact with somebody, and even if they don't have symptoms. Earlier, even with history of contact and history of travel, if you were asymptomatic, there were no tests. But now we are testing somebody who has contact history, even if asymptomatic, at least once during, in between the 5th and 14th days of exposure. Also, we have, in terms of testing strategy, we have also said that, earlier the rule was a person, before he or she is discharged from the hospital, has to test negative for the virus twice. But now we have removed that criteria for discharge. And if you're simply, without symptoms for a certain number of days, and depending on your other clinical parameters, you'll be discharged without that test, because health officials tell us that why we don't need that test. That's one test kit wasted, and it's not as if we have we have lots of test kits available, because we understand that we are getting into a phase where tests have to be stepped up. We have already done that. Our capacity is now almost close to 1 lakh per day. And we have so far done about 16,73,688 tests. So that's where the testing stands. And some people still say we're not testing enough. And also there are huge disparities between states. Delhi has one of the highest testing rates. West Bengal still has quite low tests. So actually also this doubling time figure that we are giving, many experts point out that unless you have some sort of an idea about the amount of testing that's being done, the doubling time in itself may not tell you the whole story.
You mentioned states. I mean, since health is a state subject, we've also seen different states just respond to the outbreak differently. To what extent are they relying on the center, and what has that coordination been like so far?
I don't think states are relying on the center that much, except that a lot of them have been asking for the money that's due to them, GST compensation, and if Kerala has been asking for a package. That's the kind of support that states have sought from the center, and so far they don't seem to be happy with the response. But on the other hand, what the center has done, and which many states have not liked, is that they've constantly sent these teams. First the Home Ministry sent the interministerial central team to various states. There was a huge problem with West Bengal. Initially, the team was not even allowed to work. Then I think just a couple of days back, 20 more teams have gone to the states to help the states. The center says it is to help the states, but many states feel that in the federal structure, that's not quite what they are looking at in terms of support.
You mentioned earlier that there's been slight modification in terms of how we are testing, and that's keeping in mind, the fact that we don't have that many test kits and we really need to up our testing. In what way has our treatment changed? Our treatment strategy has changed, keeping in mind that there is an ongoing burden on the Indian healthcare system.
The first change has been that in the initial days, we were very particular that anybody who tests positive has to go to a hospital. But now we've relaxed that. Now, if you're asymptomatic and if you're willing to download the Arogya Setu app, and there are a host of other conditions, then you can stay at home. That's not an option. And if you're willing to pay for it, then you can stay in a hotel, provided the hotel follows all the SOPs that the health ministry has laid down for this. Then in the hospitals, we've also demarcated facilities into 3 categories. The first one, which is a quarantine facility, is not exactly a hospital. There's somebody to sort of look at you, monitor your health, but it's not a hospital. While the next 2 levels are hospital-based, the first one has oxygen and the first level of care, and the highest has everything, ICU, ventilators, all of that. We've segregated them because there is this sense that because 69% of cases in India have been asymptomatic, they just need to be isolated. They don't really need medical care. And then there are these other beds. Also, we started off with these anti-HIV drugs, lopinavir and ritonavir. But now we have changed that. We have changed to hydroxychloroquine for treatment and also for prophylaxis. And prophylactic use of hydroxychloroquine is for healthcare workers who are treating COVID patients or family members of confirmed cases who are caregivers coming in touch with the patient. That's how it is. And the focus now in India, one trend that we have seen compared to other countries is that the period between hospitalization and death is very short. So policymakers and health experts are telling us that this is a problem area because clearly we're not reaching patients fast enough, because if we do, then this should not happen. A lot of patients, if we get to them in the initial days, they just need oxygen support and they're fine. But if we get to them late, then there's organ damage and there are other kinds of things that are set in when it gets very difficult. So that is another management strategy, not treatment, but management strategy, to tell people that if you are symptomatic, please come and get yourselves tested. The AIIMS director had made this appeal that if you're symptomatic, come and get tested, especially if you're in a hotspot. So yeah, those are the kinds of changes that have happened in the management strategy.
The Ministry of Health has still maintained that there is no community transmission in India. Some have sort of questioned that. What do other health experts have to say about that?
See, there was a piece by Dr. T. Jacob John. He's a retired epidemiologist. He used to be with CMC Vellore. And in a piece, he actually wrote that, just admit community transmission and get on with it because that's important for your management. You need to take those steps. That kind of opinion has been given by many people that, clearly there is community transmission happening and just admit it and get on with it. But also, interestingly, the government's position the last few times they've issued this clarification has always been we cannot say that there is community transmission in the entire country. And they have used phrases like localized community transmission. But I suppose there is a reluctance to come out and say those words because already there is a lot of fear among people. There's a lot of stigma. You see, even in the orange and green zones where economic activities have been allowed, they have not really taken off because people are so scared to come out. At this point of time, saying that we have community coming out and making this statement, maybe there is a fear in the government that this would actually be counterproductive.
I mean, we have now learned that India is planning on, more relaxations after this phase of the lockdown ends. From Tuesday, at least, we will see 15 trains that will become operational. What are the kind of consequences can we possibly see after that? What are the things that experts have to say about that?
See, one thing that is inevitable as you open up is that you would get more cases, and the government is prepared for that. All the projections and everything, they had factored in this decrease in doubling time as and when the opening up happens. But that is just one side of the story. There are other concerns about the economy, about getting it back on track and all that. So the government will probably have to toe a very fine line. But yeah, I mean, it's inevitable. You will see more cases. But then on the other side, there is also a chance that you will see more cases because some of the cases you're now missing out on because of the lockdown, because people are not able to reach hospitals and doctors and all that. There is also a chance that in an infectious disease, more cases is not always bad news because more cases also means those many cases are known to the system, and for those many cases contact tracing, quarantine, containment strategy, all of that is happening, which means those many cases are not spreading the disease further into the community, which is a very important thing for infectious diseases. So while a rise in cases is inevitable, there's a good side and a bad side to it, I would say.
What are the major roadblocks and challenges ahead for India now?
One roadblock is obviously, I think, to get people to come out and get tested because we've somehow made this disease almost like AIDS was at one point of time, or maybe still is. There's a lot of stigma, a lot of misunderstanding, a lot of fear associated with the disease. That is, I think, a huge challenge in the coming days, even as we open up. The other challenge is that whether our health system has the capacity to accommodate the kind of cases that we are looking at. There are projections which show like huge spurts in June and July. The question is, do we have those resources? I think that's partly why the railways did these isolation coaches in trains so that they could just go anywhere in the country to a village, to a tier 2, tier 3 city where there are not enough hospital beds available for isolation. And the Niti Aayog also has moved a proposal to convert them into full-fledged hospitals. The 3 grades of COVID centers that I was talking about earlier, this is just the first grade now, the coaches. The Niti Aayog wants them to move to full-fledged hospital with ICU, ventilator, oxygen, because they're saying that a quarantine facility can be anywhere, a school can be converted, a gym can be converted, anything, any enclosed space you get, even a tent can do. But the real need would be of oxygen, ICU, ventilators, and those are the things that the trains should have. So that's still at a proposal stage. But that, I suppose, is a huge concern right now about how and to what extent we'll be able to accommodate the patients as the numbers rise.
You'd also reported on the fact that there's an absence of field level health workers in urban areas, which are major hotspots. How much is that a concern? And what are the reasons that we don't have as many field level health workers in India?
So the National Urban Health Mission, so we started the NRHM way back in 2004-5, the National Rural Health Mission. The proposal for the National Urban Health Mission was passed by the Union Cabinet in 2013. This was in the UPA government. And then a year later, the government changed and that was not a priority. So while the name has remained National Health Mission, the Urban Health Mission did not really take off. So that in the rural areas, the ASHAs, ANMs, the community health workers that you have who know the community, who are from the community, who have the reach. Also, in a village, that structure is there where people actually keep track of each other. In the urban areas, that's less. And then you don't have any of these field workers. Even your integrated disease surveillance program, which is designed for these kinds of things, it tracks infectious diseases. It actually tracks 33 infectious diseases the year round, because it was always felt that the urban areas have enough facilities, enough health facilities. It's the rural areas that you have to concentrate on. It's the smaller districts, the small towns that you have to concentrate on. But here we are facing a situation where just hospital beds is not enough. You need the field health worker, and that field health worker cannot be your MCD sanitation engineer, because this is a specialized job for which municipal corporations in most cities are not even trained. They don't know what this is about. It's always easier if you're doing contact tracing. If a person from the community does it, half the job, I think, is done there, because person knows that family A is friends with family B, and I'm sure they must have come in touch. As for a stranger, that's very difficult. And also in, say, Bombay, where the slums are so congested, a person who stayed there, a person from the health ministry who was there for quite a few days, was telling me that how do you do social distancing in a place where in one room there are actually 12 people living? The way they normally live is that they take shifts to sleep, 4 people each, 3 shifts of 8 hours, they sleep and then they go off to work. But now there's no work, they have nowhere to go, there's a lockdown, 12 people are crammed into one room. What kind of social distancing are you talking about? So these are a lot of practical issues in urban slums that I suppose our health officials are only now realizing.
Last week, we had the Union Health Ministry Joint Secretary, Lava Agarwal. He said that it is important that we learn to live with the virus and practice behavioral changes. How was that statement interpreted, and what did other health experts have had to say about that?
Actually, many health experts have been saying something like this, that you have to learn to live with the virus. You cannot stop everything. You cannot bring your health system down to your knees. You cannot bring the economy on the brink of a collapse and fight a disease. Because, see, if your economy is down, just for an example, your economy is down, there's something called the health cess we pay. If there is no consumption, nobody pays the health cess. So that much money less from the system, that much money less that could have possibly be spent on this. I'm not saying that is the only money, but it's just a very small example of how there's a snowballing effect of a lockdown on various other things that can eventually reflect on the way you fight the virus. Whereas if you actually practice all these hand washing, social distancing, physical distancing, all these norms, there will still be casualties, there will still be cases. But maybe you might be a little better off otherwise. And there is actually international example of that. Sweden, it was a very controversial decision. Sweden did not lock down. People were very critical. Now, actually, Sweden's fatalities are rising, so there are still question marks. But here's the thing: Sweden did not close down, Denmark did. They are same kinds of countries, similar culture, similar kinds of people, all of that, similar kinds of health systems, similar kinds of health spending. But with a lockdown and without a lockdown, their fatalities are actually comparable. It's not as if Sweden has gone through the roof and Denmark has stayed stable. Their death figures are comparable. Closing down buys the government time to get its other preparations in place, get the oxygen cylinders, get the masks, get the beds. For example, these railway coaches. This could be done because the government was focused just on that at that point of time. But now that you've bought yourself that time and you've reached a certain place where you can possibly control cases better than maybe you could have in March, there is this increasing feeling in the government that maybe it's time to open up. And many epidemiologists have been saying that on record and off record that it is time to open up.
Among the list of epidemiologists and experts that have said this, has been Dr. Randeep Guleria, the director of the All India Institute of Medical Sciences, and who is part of the core team monitoring the coronavirus pandemic in India.
So the ideal issue and the dream would be to have zero cases, but I don't see that happening in the very near future. We will have to literally live with COVID-19 for quite some time and also realize the fact that when it comes to running our, let's say, coming back to our new normal, we will have to have strategies which will be able to work or which we will have to develop with COVID-19 being around. Whether it's travel, whether it's work, whether it's related to other things, it will have to be with COVID-19 being around.
The Indian Express recently hosted an e-Adda, a discussion with him about the virus and India's outbreak. This was moderated by Indian Express's principal correspondent, Conan Sheriff, who now joins us to share its highlights.
So the key highlights of the interview was that the first big takeaway from the interview was that the virus is here to stay for a long time. So it's a big battle ahead for us. He says that the virus could peak in the next few months and it's going to stay here for a long time. We asked him about what has the lockdown helped us. He said the lockdown has helped us in keeping the numbers under control as compared to other Western countries, whether it's the US or the European countries.
If you look at the number of cases in terms of other countries, we have a less steep rise, although the cases do continue to increase. So that is something which is satisfying because it hasn't really overwhelmed the healthcare facilities as it has done in many countries. And we all know that our healthcare facilities are already stretched to some extent. We are a resource limited country, but we managed as of now to be able to not have ICUs or hospitals full of COVID patients as has happened in many Western countries.
Then from the data that has emerged out from the country in the last few weeks, he says that the virus is much more smarter than what we thought. A large number of patients in India are now turning out to be asymptomatic, which means that it's going to be a big challenge to trace these patients, and these patients could be potentially spreading the virus to more vulnerable population. So that's a big challenge. And he also points out that there's evidence now that the virus is not just affecting the lungs. We thought that it's just a respiratory disease. So there is evidence that the virus is now affecting other body parts.
So there is now evidence which is coming up that this virus not only affects the lungs, it causes a hypercoagulable state, that is cause clotting in the blood. It causes swelling of the blood vessels, what we call endothelitis, and therefore it causes involvement of the heart, what we call myocarditis. We've had a few patients who presented with stroke and subsequently developed respiratory symptoms and were diagnosed to have COVID positive. So this is now being reported even in the West, that you can have neurological manifestations in patients who are COVID positive. And we're realizing that even other organs like the kidney or in some people there may be diarrhea can also happen. In majority, it will be the respiratory involvement, but you can have some atypical presentation, and that's why you should have a high index of suspicion.
On the data, just the data, he says that we haven't been able to flatten the curve. It's still rising. It's not showing a declining number of cases. So the focus really has to be the hotspots.
I would say that in the cold spots or the areas which are not hotspots, the green zones, one will have to continue to do a syndromic surveillance because you want to be sure that in those areas you're not missing out a cluster or an outbreak which may happen because of someone coming to that area or a COVID-19 coming to a cold spot, a green area, and that actually turning into a orange or a red zone. So there has to be a very active surveillance which has to be done at a district level, at a state level, and at a national level. The data has to be analyzed on our sort of live regularly. At the same time, one can also look at strategies for testing in these areas. You could do what is known as a pool testing, where number of samples could be pooled for people who have ILI, and you see whether any of them are positive. Because if they are negative, then you can say this is a non-COVID ILI, and this is an area where you're having influenza-like illnesses, but this is not COVID related, and therefore this area continues to be green. So there you will have to develop strategies both in terms of surveillance and in terms of making sure that the green zones remain green.
And then he spoke about the treatments. A lot of been spoken about hydroxychloroquine and, of course, remdesivir. He said that data still emerging. There are various clinical trials underway in India also. So he's saying that we still don't have treatment, but we are hopeful that these drugs and also other treatments like the plasma therapy is being examined. And in a few weeks, we should have some evidence on these treatments. And finally, how the post-COVID world is going to look. teleconsultation in hospitals is going to be the new normal, how we have to start living in a world where COVID-19 is going to be a reality.
Two things are going to happen, and it may be looked as an opportunity if you want to put it that way. One is the whole issue of what I would say is teleconsultation. And because of the fact that you're talking of social distancing and not having patients who are sick coming to the hospital, there would be a lot of push to have consultations which could be done either using your phone or through video conferencing, and being able to look at patients, advise them, and talk to them virtually rather than them having to come to the OPD. Now, some patients are doing this for some time, and some patients find this useful because they feel it saves them the time of travel. At the same time, they don't have to wait for many hours outside the clinic or the OPD to get their appointment. It's done from their house, and therefore it's more comfortable to them. Especially the elderly and those who have chronic illnesses who just need advice on, let's say, a diabetic or adjusting his insulin dose, or a person who needs some advice on adjusting his blood pressure medicine. This type of consultation is something which would be useful rather than him having to come to the hospital and then wait there for a long period of time and also have the risk of getting infection. So one is teleconsultation will become something that will become a new normal. Secondly, there would be changes in how you examine patients and how we interact with them in terms of more and more infection control measures, social distancing while examining patients, wearing a mask while examining patients, and regularly washing your hands or wearing gloves will also become something which will be a norm. It will also for some time change how we go about doing surgeries, being extra careful in terms of infection control, and also in terms of how do we do procedures. So there will be dramatic changes as far as the management strategies are concerned.
You were listening to Three Things by the Indian Express. Today's show, as always, was edited and mixed by our producer, Joshua Thomas. If you like the show, then do subscribe to us wherever you get your podcasts. You can also recommend the show to someone you think will like it. Share it with a friend or someone in your family. It's the best way for people to get to know about us. You can also tweet us at Express Audio and write to us at podcasts@indianexpress.com.